So, hello everyone, and a very warm welcome on behalf of EuroELSO. This is our newest webinar with the topic Hypothermia for Everyone, the Hypo ECMO study. And it's a special pleasure to announce that we have Bruno Lévy from Nancy, France today with us, who is the expert as he has been leading an interventional study on the subject. And we are very glad and thankful, Bruno, that you take your time today to share your knowledge with us. And just for those who may not have been joining our webinars after the presentation, you will be able to put in your questions in the webinar tool, question tool, and I will moderate the discussion and try to make sure that all of your questions will be answered by Bruno. So thank you once again for being here, and this is your stage, Bruno.
Thank you very much, Peter, for this very nice introduction. Thank you very much also for the invitation. It's a real pleasure for me. So during the next 20-25 minutes, we will discuss the place of hypothermia during VA ECMO, and data are mainly based on the results of the Hypo ECMO study. First slide, this paper is very, very interesting, and you can see further definition. And during the presentation, we will speak about moderate hypothermia, which is generally between 32 to 34 degrees. And of course, it's not a deep hypothermia, for example, less than 30 degrees. And it is very important to note that the effects of hypothermia, and especially moderate hypothermia, mainly depends first on the induction speed, second on the duration, third on the rearming speed, and of course, it also depends on the adverse effects management. First, and as you know, hypothermia induces many effects on the cardiovascular system. The first one is a decrease in heart rate. It is a proportional decrease in heart rate. The second one, which is logical, is a decrease in cardiac output, which is proportional to the decrease in heart rate. Generally, it's observed no change or a moderate increase in arterial pressure, an improvement in cardiac contractility, at least in animal models, and a decrease in myocardial oxygen consumption. And the decrease in the myocardial oxygen consumption is higher than the decrease in cardiac output. Some potential side effects of hypothermia has been described, and the most known is coagulation. If we use moderate hypothermia, generally it's possible to observe platelet dysfunction, a slight thrombopenia, but generally no bleeding. Hypokalemia might be secondary effects. There is also some effects on the effects of drugs, generally an increase in plasmatic drugs levels, and it was described, at least after cardiac arrest and hypothermia, an increase in infection and hyperglycemia. And you know, cardiac shock is associated with major ischemia reperfusion injuries. And right part on the slide, you can see a figure that illustrates the main mechanism implicated in the protective effects of mild hypothermia against ischemia reperfusion injury. And the mechanism are separated into early in black and late in gray. It is important to note that this presentation was initially addressed to brain ischemia reperfusion, but it may be for a large part be applicated for all organs. As you know, the patients treated with VA ECMO likely have the most severe ischemia reperfusion injury. And as you know, more than 50% of the patients of cardiogenic shock treated with VA ECMO had a cardiac arrest before ECMO run. it's I think it's 75% is a less study, which is ECLS ECMO, ECLS study from Olgarty, which was recently published in the New England. Concerning the potential effects of hypothermia during VA ECMO, of course, brain protection. This might be discussed because, as you know, nothing is proved concerning the efficacy of hypothermia after cardiac arrest, the prevention or the mitigation of organ injuries, and in some animal models, a cardiac and vascular function improvement. And of course, we have to keep in mind the potential side effects, such as bleeding, an excess of bleeding, and an excess of infection. This slide is very classical. It's the old paradigm of cardiac shock, which is mainly cardiac disease with ischemia, pulmonary edema, hypoxia, and cardiac dysfunction. And the new paradigms, which add some vascular part to the cardiac injuries. And clearly now cardiac shock is a combination of cardiac failure, also of vasopressia due to the production of nitric oxide, peroxide, etc., etc. So patient might be treated with inotrope, but also with vasopressor, and for refractory cardiac shock with VA ECMO. What we know concerning hypothermia during cardiac shock, data very scarce, and the randomized shock trial was published in Circulation. It's a paper published by Holger Thiel and his team. It's an interesting study, but the study mainly addressed cardiovascular points. And the main endpoint was the evolution of cardiac power index. And they did not find any differences for cardiac power index. And secondary endpoint were, for example, as represented here, the total amount of norepinephrine. And as you can see, there is no differences in the use of vasopressor in cardiac shock patient, complicated acute MI, and treated or not treated with moderate hypothermia. Nevertheless, this was only a pilot study, clearly not powered for mortality, and they did not take into account extra cardiac properties of hypothermia. So, in this situation, the role of VA ECMO, which is more a circulatory assistant rather than a cardiac assistant, is to break the vicious cycle associated with ischemia reperfusion. So, in increasing blood flow to the organ, via ECMO hasten organ ischemia and decrease shock-associated inflammation that leads to vasopressia. And of course, it is necessary, I think, this is not definitive proof, to use ECMO before, if it is possible, the apparition of organ failure and multiple organ failure. And as you can see on this slide, you can see that hypothermia may act at different timing and different pathways during cardiac shock evolution, treated or not treated with VA ECMO. Before the clinical study, we perform in my labs with my team. Next month, we perform an experimental study in pigs. Pigs were treated after the induction of cardiac shock, ischemic cardiac shock. After the run of ECMO, they were treated with normothermia or hypothermia. And with the same global hemodynamic, same mean arterial pressure, we found that moderate hypothermia in pigs was associated with less fluid, clearly less norepinephrine, faster lactate clearance or faster decrease in lactate levels, because lactate clearance is clearly not a good term, a better cardiac function, which was appreciated in using a mirror catheter, and a better vascular function, which was appreciated in using, as you can see here, dose response curve. And here we use incremental doses of norepinephrine, and we measured in our pigs the increase in mean arterial pressure induced by norepinephrine. And as you can observe, the pigs treated with hypothermia here had an higher, better answer to norepinephrine when compared to normothermic pigs, which is clearly a restoration of the vasopressor properties of the vessels. So after this experimental model, we decided to back to the clinical scene, and we performed the study, which was published 1 year, more than 1 year ago in the JAMA, the Hypo ECMO study. This was a randomized control study, of course, and open. This is the design. First, the patient had to be included within the first 6 hours after VA ECMO initiation. 2 groups, moderate hypothermia and normothermia. Moderate hypothermia, we use 33 to 34 degrees. We used the heat exchanger of the ECMO device to maintain the temperature. Moderate hypothermia was maintained during 24 hours, as described here. And after that, the patient was reheated through a slight increase in the temperature, 0.2 degree per hour, and the temperature was maintained in a normothermic state for a total duration of 92 hours. For the normothermia group, it was the same protocol, and the normothermia group was 36 to 37 degrees. Here the endpoints, we use crude endpoints since we use mortality, and this might be discussed, and you can find some important point of discussion in this paper. This paper is now was now published in the Lancet Respiratory Medicine, and we discuss the point of the question is, does mortality is a reasonable endpoint for cardiac shock study? And we also use many secondary endpoints. The main one was a composite endpoint of the main cardiovascular events. So death, of course, cardiac transplantation, stroke, escalation to Lévy particular side device, and at after 30, 60, and 180 days. We also studied the mortality at different times, the duration of VA ECMO, ventilatory 3 days, renal replacement therapy 3 days, total amount of vasopressor, total amount of inotropes, lactate clearance, etc., etc. And of course, we were interested in appreciate the safety endpoints. So we measured the rate of severe bleeding, the presence or not of sepsis, pulmonary, broad sleep, and ECMO canalolating, and the number of packed red blood cells that was transfused during VA ECMO therapy. The statistical analysis was very classical, and this point will be discussed after. So we use a classical Cox model. You can see here the main inclusion criteria, which was very simple. We included, it was a multi-center French study, so approximately all the university hospitals that perform ECMO in France were included. And for example, contrary to Germany, ECMO in France is localized in approximately all the university centers, but only in university centers, because we work in network, and ECMO VA at least is not available in center without a cardiac surgery, for example. So very simple inclusion criteria and some very important non-inclusion criteria. First, we did not include CPR patients, so refractory cardiac arrest after out of hospital cardiac arrest, not in hospital cardiac arrest. ECMO for LVAD or heart transplantation were not included. Uncontrolled bleeding, uncontrolled means after surgical intervention or medical intervention, for example. Moribund patients, acute poisoning with cardiovascular drugs such as beta blockers, for example, and a cardiac arrest total duration higher than 45 minutes. The flow is here, and we randomize 374 patients, and we have data for a majority of our patients. So in each group, 168 and 66 patients. Concerning the result, concerning the population, first point, approximately half of the patients experiment a cardiac arrest because VA ECMO run, 47%, and the distribution was the same in both groups. If we have a look at the etiologies of cardiac shock, the first one was ischemic cardiac shock. Approximately 35% of the patient with acute myocardial infarction, and 22 to 23% of the patient with chronic ischemic cardiomyopathy, which is clearly not the same. Non-significant part of rhythmic cardiomyopathy, small part, but interest part of patient after cardiac surgery and after some cancellation of miscellaneous etiologies. The patient were classical, left ventricular ejection fraction before via ECMO, of course, is low. Patient had lactic acidosis and low pH, elevated lactate levels, high degree of organ failure, and the majority of patients were treated with vasopressor. Just keep in mind that we have 6 hours to include our patients. Some patients that were included did not have any vasopressor because they were treated with ECMO for 2 to 3 hours in some patients. The use of ECMO clearly allows the withdrawal of vasopressor. But all the patients before VA ECMO run were treated with vasopressor, and many with norepinephrine. First results, it's a very good results. The protocol was respected, so we were able to maintain the temperature in both groups. You can see in orange normothermic patients, and you can see here in blue the hypothermic patients. So the decrease in temperature, after that the normalization, the maintain of the temperature, and the slight increase, and after that the maintaining of the temperature. So first results, we are able to clearly distinguish two different groups, the normothermic group and the hypothermic group. And if we have a look at the main results, it's complicated. It's complicated because, as many studies published in the JAMA, it's an inconclusive studies. And we have to discuss these points. So if we have a look at the mortality at 30 days, 42% versus 51%, but this was not significant if we use the adjusted odds ratio, which was the statistical method that we published before closing the database. And we will discuss some particular point after. Nevertheless, if we have a look at the secondary outcome, we find that after 1 month, patients treated with moderate hypothermia were different concerning the occurrence of the secondary endpoint when compared to the normothermic patients, and this was in favor of hypothermia use. So the results are inconclusive. So it's very important to have a look at the side effects. And if we have a look at the side effects, first, transfusion and bleeding. So moderate, the incidence of moderate or severe bleeding, no differences. Slight increase maybe after, maybe it's important also to consider more units were transfused in patients who bleed when they were treated with moderate hypothermia when compared to normothermia. If we have a look at the septic complication, no differences, at least, and this is difficult to explain, less bacteremia in the hypothermic group. So if we consider the whole side effects are very small, no more bleeding and a slight increase in pancreatic both cells in patients who were treated with hypothermia. We performed, and this was a part of the paper, a Bayesian analysis, and we find that considering the hypothesis, minimally informative or moderately enthusiastic, you know that Bayesian analysis is slightly complicated. We observe a mortality benefit with hypothermia in 94%, 99%, and in the less positive hypothesis, the probability, posterior probability of mortality benefit with hypothermia was higher than 85%. So this is also a positive sign for the efficiency of hypothermia during VA ECMO. There are some study limitations. First, we included only intubated and sedated, mechanically ventilated patients. So patients who had ECMO in spontaneous ventilation were not included. And you know that now it's a great part of our patients. We included patients, the inclusion was heterogeneous since we included ischemic patients, arrhythmic patients, post-cardiosurgical patients. I think this is not a limitation. This is a fact. Patients with cardiac shock, severe cardiac shock, generally experiment a cardiac arrest. And of course, the study was slightly underpowered to detect the 8 to 10% survival that we hypothesized before the study. First conclusion, this is not the conclusion of my presentation. Early application of moderate hypothermia for 24 hours did not significantly increase survival compared with sleek hypothermia. But because the 95% CI was wide and included a potentially important effect size, these findings are not negative. This was highlighted by the statistical review of the JAMA, but considered to inconclusive. We found a positive effect on with a lower risk of the composite endpoint. We find also that hypothermia was associated with more days alive and without organ dysfunction or renal replacement therapy. And clearly, we find the same rate of hemorrhagic and infectious events in the two groups. So one question, and we will discuss during this part after, it's not now the largest LCT, and the largest LCT is now the ECLS ECMO, but the study was only performed in acute myocardial infection. Important point for me is if we compare hypothermia to a new drug or a new device, it's inexpensive because we use the heat exchanger of the ECMO device. So the cost of society is equal. We did not find any safety concern, and the post-hoc Bayesian analysis is in favor of hypothermia use. So my personal conclusion, first conclusion, I think because it's safe, because it's cheap, and because there is some doubt about the efficiency, I think it might be used, it should be used in our patient if we respect the ECMO inclusion and non-inclusion criteria. Of course, some general recommendations, sedation should be the lightest possible. it's also interesting to avoid paralytic agents. And of course, at least for the patient with cardiac arrest, neuroprognostication is essential and should not be delayed if possible. I have, if you allow me, Christian, a part of comments. I think that might be interesting to discuss. First, we did not include any ECPR patients. And this is clearly an open question now. If I have a rapid look at the literature, and the literature is not very clear. Some meta-analyses find the positive effects of therapeutic hypothermia associated with ECPR. And for example, you know that the PRIDE study, for example, was performed with hypothermia. There is no randomized study which compare ECPR with or without hypothermia. What is known is that there is no more bleeding if we use therapeutic hypothermia during or after ECPR. And in some study, there is no advantages. So I don't know. In my units, we use, if it is possible, moderate hypothermia in this patient associated to over therapeutics. Second, the difficulty of using or choosing statistical in clinical studies. And this is important. We choose to use the odds ratio. And during the reviewing, the reviewer said you choose a bad test for this kind of patient, and you should have used a risk difference. And this is explained here. And you can read because why it is better in this kind of study. And if we have choose the risk difference, and this is in the paper, the study would have been positive with a very, very important difference. And you can see that up to 19 lives might be safe for every 100 patients treated. This point is important. Second, we perform post-hoc analysis, and this paper was now submitted and not accepted. We use win ratio analysis, which is statistical techniques to better analyze, especially the composite score. And you can see here that the win ratio analysis is clearly in favor of hypothermia use at 30 days, but also at 60 and after 6 months. And the important point which is added by the win ratio is that it is very easy to see that the main component of the difference is death. It's not stroke, it's not LVAD, it's not transplantation, it's not organ failure, it's death. So clearly the win ratio and the positive effects of hypothermia is mainly led by the decrease in death. We also perform a post-hoc analysis, and we separated the patient with cardiac arrest and without cardiac arrest. And it is very interesting. Of course, the cardiac arrest that were included in the ECMO study were very selected. So the low flow was low, the no flow was very, very low. It was mainly in hospital cardiac arrest. Of course, yes, this is right, but at least more than 1/3 of the patients were implanted during cardiopulmonary resuscitation. And we observe a very important effect of moderate hypothermia, especially, and that is only in cardiac arrest patients. And you can see here, sorry, well, yes, I have to move that. Donc, in red, the no cardiac arrest group, and in blue, the cardiac arrest blue, and you can see that the difference is very important. So, maybe a signal with important signal in patients treated with cardiac arrest. We also observe a cardiac arrest in de novo heart failure when compared to worsening. But I think this is also due to the difference in the patient, and de novo heart failure is mainly acute myocardial infarction, and there is clearly more cardiac arrest in this subgroup of patients. So my definitive conclusion, based on the preliminary results, especially the composite score, the Bayesian analysis, the win ratio, and mainly the post-hoc study in cardiac arrest patients, it is likely, it is my opinion, that moderate hypothermia improves survival in intubated ECMO VA treated patients. And of course, the probability of a positive effect is higher in cardiac arrest patients and in de novo cardiac failure, which is for a part the main patients, and the same conclusion than previously. It's not expensive, it's very simple to implement, and we did not observe in this sort of patient no safety concern. So thank you very much for attention, and I'm waiting for the question. Thank you.
Bruno, first of all, thank you so much for the great presentation, and also thank you very much and congratulations to you and the entire group in France for conducting this study. I assume it must have been a huge effort to do that, and I really admire the effort of your group to do that. I think you have made a very clear presentation of the data, also on the complexity of the analysis, and especially your conclusions and also your personal comments, in my opinion, are very fair, and make this, after all, even though you can say technically that's a negative trial, a very promising therapy. So I think the question for a lot of doctors in health, associate healthcare workers who join this webinar is what should we do? I mean, the question will be, what will the next guidelines say? So my kind of personal question would be, do you use it in cardiac arrest patients? And if you do, is it only the patients after CPR or also the other cardiogenic shock patients on ECMO?
Thanks, Peter, for this good question. We use it. We use it clearly. We use it for the patients which correspond to the hypo-ECMO criteria. First, and as you know, we implant ECMO now, I think at least in my center, for the majority of patients, it's in non-intubated patients for cardiogenic shock, majority. So for this patient, it's very difficult, and we have no data difficult to implement hypothermia in a conscious patient. It's very difficult. This was done in myocardial infarction, for example. I think it's difficult because we have shivering. I think it's very difficult to maintain a patient at 34-degree conscious patient. Maybe we can work on it. Maybe we can use slide sedation. We can use some. I think it's difficult. So we use it in all our patients that are intubated. And we use it not only in cardiac arrest patients, but also in the other patient because, and this was my last slide, first, we did not find any safety concern. And even if we observe some safety concern, it's very easy to increase the temperature. So arrhythmia is not a problem after cardiac arrest, after patients we sustained by VA ECMO. We did not observe any infectious concern. And concerning bleeding, of course, there are slight amount, more units of blood transfused, 5 versus 8, when the patient is transfused. Okay, we can deal with that. We can deal with that if we think that the results of hypothermia is to increase survival for, I don't think it's the theoretical number of 19, but I think it's too much, but I think there is a real effects. So in my units, we also use hypothermia for cardiac arrest in non-VA patients. So in France, it's approximately 2/3 of the units choose to use normothermia, and 1/3 of the units choose to maintain normothermia. And for this patient non-treated with via ECMO, we choose to treat the patient with hypothermia. And if we observe, for example, arrhythmia or severe bradycardia, it's very easy. We have some device to maintain the temperature, to increase the temperature to 35 to 36, etc., etc. So we use it. We use it also in ECPR patients, but this is a very different kind of patient. And these patients were not included in the Hypo ECMO study, so we do not have any data. But if the hypothesis is hypothermia is able to decrease the intensity of severe ischemia hypertension injury, of course, it might be a very good place to use hypothermia. And we schedule to present a grant with Alain Combe concerning this very special patient.
Okay, so I hear your message very clearly. You use it because your data cannot definitely prove it, but makes it very likely that there may be some positive effects at no cost in terms of side effects, and it's a very cheap therapy. And I think that's a very fair conclusion. So I'd like to go into some details. You mentioned that the CPC rate of ECPR survivors in the study was 47% for grade 1 to 2. Maybe for those colleagues who join us who are not that much into CPR business, can you compare this outcome maybe to other cohorts of patients? Is that something you can expect, or is it a good outcome?
Yes. Okay. These are the, okay, I think it's cardiac arrest and no cardiac. Yes. It's interesting to have a look at the characteristic of our patients. ECPR is not, first, it's not out of hospital ECPR. These patients were really different, and especially the no-flow is very difficult to determine. Sorry, the patient, we did not know, the emergency arrive and say, I don't know when the patients were in cardiac arrest. So we excluded this type of patient. So it is in hospital cardiac arrest. The typical patient is patient with acute MI, goes to the cath lab and cardiac arrest. So we try to perform a classical resuscitation during 3-4 minutes, and after, so we call the ECMO team and we implant the patient under cardiac massage. So these patients clearly are patients with a good, previsible, good prognostic after cardiac arrest, because no flow is very low, because low flow is not so long, because we're in hospital with the surgeon that are immediately at the bed of the patient, and all except the patient were witness. So the results are very good, and all the survival patients were in CPC 1 or CPC 2. So I think if we consider the inclusion criteria of Hypo ECMO, we choose to include patients in which a priori we think that the prognosis will be good, at least for the brain. Is it clear?
Yes, it's very clear. So the next question would be, if I think of your first slides, you introduced that the timing of hypothermia induction is very critical. Now, I may have overlooked in your presentation, what was the median time of hypothermia start after ECMO initiation?
You can see the curve. And the curve is here. First, it is interesting to note that in both groups, and this is logical because it's cardiac arrest, both groups arrive in a state of moderate hypothermia. I don't have the precise number here. So the induction of hypothermia was very fast. Very fast because the patient were out of hospital arrest, in hospital cardiac arrest, was in the cath labs, etc., etc. So the temperature decreased. So the induction was very fast. And we tried, I think this was very, very well respected, was to maintain the temperature, to have a very slight reheating, and to maintain the normothermia during, we choose 72 hours after the first 20 hours in order to avoid a rebound. So these are the classical recommendations for cardiac arrest. And we apply this recommendation to our patients concerning the use of hypothermia.
I would like to extend my question to the time point of ECMO initiation until randomization, because I understand the protocol allowed 6 hours after randomization, after ECMO start, you could randomize the patient.
Yeah.
Do you know how long it took in average from ECMO start to randomization?
The median time from VA ECMO to randomization was 3 hours.
Okay.
The median time from randomization to the first measured temperature, because we choose to use internal temperature. So it was in majority of centers, it was not possible to measure the internally measured temperature, for example, in the cath labs. So the first temperature was measured in the ICU. And the median time from the randomization, because generally we are able to randomize the patient even if the patient was still in the operating room or in the cath labs, and the median time was 40 minutes. So it's very, very close.
Right. So assuming that hypothermia gives the positive effect, would it be fair to assume that if we started the patient right after ECMO initiation on 33 to 34, that the effect might even be bigger?
I don't know.
I don't know. Is that your daily practice? If you cannulate a cardiogenic shock patient, that
yes.
You start from the beginning, right?
Yes, yes. Now, for example, a patient arrives in the cath labs. We put ECMO. We put ECMO or in the VA ICU, and immediately we put you use VA exchanger or even more precise device such as this one. This one is very, very with a feedback very easy to use and very precise, and this is a feedback. So you put 34 degrees, and it's very, very easy to decrease the temperature. So we use it immediately now. But I don't know if 1 or 2 hours might lead to a very different result. I don't know. This is because you have a lot of things to do during you are in a great part for our patient. We are not in the ICU, but out of the ICU because at least in my institution for patient for myocardial infarction, the arrival is directly in the cath labs, and the patient is in shock, not immediately in shock, not like in the SLS study, but if the patient had a cardiac arrest or very decrease and a very low blood pressure despite the vasopressure, we put immediately the ECMO. So if we put immediately the ECMO, we induce also hypothermia immediately.
Yes. So I would like to talk about the physiologic changes. Did you monitoring physiologic outcomes in a way during the time of hypothermia, and did you see differences between the normothermia and hypothermia group in terms of vasopressor demand, in terms of cardiac output, things like that?
So didn't find any differences, and this was a surprise for me. Concerning the use of vasopressor. For example, concerning the number of patients treated and also the dose of vasopressor. We did not find any differences, but okay. If we compare to septic shock, for example, at least one study that demonstrate a decrease in vasopressor demand when we decrease the temperature. We did not observe it. And this was a multi-center study, so We did not search for over physiological effects. The lactate clearance was not different. We observed very interesting patterns of lactate evolution during VA ECMO, and this was also a study that we have recently subject, but we did not find any differences for the lactate evolution according to the group. It's the same.
That's interesting. And
this
maybe...
is also interesting, but we have to keep in mind that the intervention lasts for 24. I can see after 36 hours, the temperature was the same. So it's difficult to implement different results, a very short intervention and a very long observation period. So this is complicated.
So do you think this could be due to the fact that the intervention may have mainly targeted or acted as a neuroprotection, since you saw the effect also mainly in the ECPR population?
I don't know. We mind for one question might be why these results appears to be different for cardiac arrest patient, for example. I don't know. I don't know. Clearly, there is cardiac shock complicated by a cardiac arrest. It's not the same patient than a simple cardiac arrest. And if you have a look at the main studies of TTM, concerning TTM, and the most TTM2, it was the most recent. The incidence of cardiac shock was very low. Of course, when compared to this patient, it's 100 versus 20, 30%. So it's not the same patient. So there is a brain part, but we choose some special patient for brain aggression, but also the cardiac part, the cardiac effect, the vascular part, the kidney part, coagulation. So I don't know how to explain the apparently positive result. For me, it's positive in favor of hypothermia when compared to a classical patient with cardiac arrest. I don't know.
Okay. So at least we can say that, considering the experimental data you published first, men do not seem to behave like pigs.
Yes.
Yeah. So maybe some practical aspect. There's a question coming in. I understand that this is a passive cooling in terms of you just didn't turn up the heater, right?
Yes, but it depends on the center. It's here. I think we change a little bit. So generally, the patient is slightly hypothermic, and it's very easy to maintain the temperature with this device, which is passive. We also use this device, which is generally used in the operating room. So it's clearly a device. It's blood, and blood is heat or cold directly, and there is a feedback. So, and sometimes we also use now patients some blanket, external blanket, and it's also very easy to use, even in patients treated with via ECMO. So we can use these three devices especially according to our patient. In a majority of French center, this was used. So it's clearly passive reheating and passive maintaining the temperature. And it was also so very easy to read the patient. I was surprised by that, because but you have to change the temperature, and the patient reads slightly, very slightly. And it was very easy to maintain the temperature.
So there's a question from Fernando, who asked, did you see any potential effects on the heart recovery in differences between the groups? Or maybe did you have any signs or recordings that there was a limitation of heart injury in the intervention group, especially of those with ischemic origin? Did you assess any data on that?
No, unfortunately, no, because for that we need more money. You know, yeah, because it's multi-center study, so we have to have the patient to perform an echo, to perform a cardiac exam, etc., and we need money for that. So we have grants for that, and I hope for a positive answer. I think it's we have to deal with after that the patient two years after the VA ECMO. So I'm not sure that it will be possible, but maybe we can also have a look at the follow-up of the patient, the regular follow-up. But we need some authorization for that. So it's complicated. Just it's impossible to phone and to say for Bordeaux, for example, please have a look, phone to our patient. We need to have ejection fraction. We need to have an echo, because an echo, I don't know how it is in Germany, but in France, it's 100 euros. And we have also to pay the patient if we need an ambulance to go to the hospital. So I think to have a follow-up for one patient, it's 300 euros. Okay. So for half the patients, it's 200 euros for 150 patients.
Okay, we put up
we need money to.
We put up a fundraiser after the webinar.
Yeah. Yes, thanks.
So Bruno, I mean, do you think it would be possible to do another trial on this, given the fact that depending on how you look at the data, this is somewhat of a positive signal in this study? And would you do it, and would there be any funding for it?
So I don't think so.
Yeah,
I don't think for many reasons. The first one, and I think it's a problem. I don't know in other countries, but in France now it's a problem. There is too much study on VA ECMO. So we have a national system of grant from the France Health Ministry, and we have to include it, if we consider all the accepted grant, more than 1,500 patients for the next 6 years, for example. So it's a very big number. It's a very big number. So the study is very close. I think it's a physiological study. I think we do not need more data. It's not a drug. I think all the important points were explored by the study. Especially the side effects. ECMO patients are generally in very specialized units. I think it's we have no time, no patients to perform a study which have to enroll 600 patients, for example, to fight. I think we have a posteriori, we have calculated that 100 patients would have been needed to have a positive effects concerning the primary statistical analysis we chose. So I think it's complicated. You know, you see the CLS study. I have some problem, not with the study, with the interpretation of the study. So we have to, I think the more important point for me is to perform via ECMO in the right patients. And this is, for me, useful because we have to improve the way to perform ECMO in these patients. So we have to mind for the best vasopressor, we have to mind for the temperature, we have to mind for the winning tactical, is it, we have to use levosimendan, for example, to it. This is a very important question. And temperature for me, now we have, I think, a big study with important results, and each center, I think, have the power to choose if you want to use or not to use hypothermia, and in which patient you want to use. I have to reverse the question. Do you, Peter, do you use hypothermia in cardiac shock patients treated with VA ECMO, for example? The sound, please.
So I work in Vienna, and that was the center who was leading the first New England trial on hypothermia in cardiac arrest patients, which was positive. And we have still a very big research group on the topic, and they have many arguments why hypothermia in cardiac arrest is a good thing to do, despite of the, you could say, unclarities in the literature that have come up in between. So yes, we do hypothermia regardless if the patient is in cardiogenic shock or whether the patient is on ECMO after CPR. And we don't routinely until now in cardiogenic shock without CPR before ECMO. But I think according to these data, we definitely should consider. And I will be very open to discuss with my teams because you have given a very, very good rationale for that. And I think your study is just like the other big ones that came out the last years. Take EuroELSO, take the Prague shock study. If you only read the abstract and see something wasn't statistically significant, that's not the entire answer, right? And if you take away the crossover of some studies, the studies would have been very clearly positive. And I think the same can be found in your study. You need to look into the details, do the right interpretations. And what I especially admire about your study is that you already, before you did everything, you made sure that you would, with proper secondary analysis, would be able to look at the results from different angles. If you, for example, consider the Bayesian analysis that you did. Thanks. So I think we as clinicians have sort of the duty to go more into detail, to maybe join webinars like that and take the great opportunity to listen what you have to tell us about it. And yeah, that's just part of our job, that we need to go in the details to make up our minds and go with what we have. And it's a lot, to be fair, what we have with this study.
Okay.
So I don't see any more questions coming in directly connected with the issue. I mean, we could talk about a lot of aspects of hypothermia in maybe in VV and in special situations. I think that's a bit of the topic of the webinar. Bruno, yes. I ask you if there was any more that you would like to share with us, or if you maybe have a final comment on the whole topic.
No, I think I really appreciate your conclusion, and I think for intensivists, for our younger intensivists, it's very important to read the paper and to discuss the paper. I have also to thank the statistical reviewer, the JAMA. He did a very good job, and the paper was sent. I wrote it's a negative study, and first comment is no, it's not a negative study. You can it's impossible for you to write. It's an unconclusive study, and for my part, I think it's a positive study. This is very interesting, very smart, and we discuss a lot with. And for I think it's a very good reviewing for me because it was interesting. We changed the paper, and we slightly changed our mind afterwards. So read the abstract. But for this important part, especially if you read unconclusive, you have to do your opinion in reading the paper and discuss it with your team, and to look and appreciate if it is you can transpose the result to your team, your practice, etc., etc.
Great.
Thank you very much.
Thank you very much again for sharing your time, for
Real
sharing your
pleasure for me
expertise.
to be with you. Really, really
Thank you. Thank you for our participants. If you came in late, please know that you will be able to download the recording of today's webinar, which should be online in the next couple of days, either on the EuroELSO website or on YouTube. Make sure to follow our social media channels, because there are some more exciting webinars coming up that should be announced soon. And also, please mark in your calendar that we have our EuroELSO annual meeting in Krakow, Poland next year, April 24 to 27. With this, I would like to thank all of you once again, and please remember, you're only on the safe side if your venous line is blueberry and your arterial line is cherryberry. Thank you for today, and goodbye.
Thank you very much. Thank you very much. Bye-bye.